Hello and welcome to Pain Management 101. This is the first lecture in a series of lectures that are structured on pain management. In this lecture, we will learn a little bit about pathophysiology of pain, some of the pain statistics, and why should we care about pain. Also, what are some of the assessment and management options? And lastly, how does compounding actually factor in a practice of treating pain? So let's move forward and let's look at the Institute of Medicine report that was published in 2011. So this report was titled Relieving Pain in America, and it was published because Institute of Medicine conducted this independent investigation and basically looked at the problem of pain as a national health problem. So they asked themselves that question, and the question they asked was, why should we care about pain? Why should anybody care about pain? So who is Institute of Medicine? Institute of Medicine is a nonprofit organization that works outside of the framework on government, and what they do is they look at the problems such as pain management, or it could be anything like diabetes. They conduct their investigation, they look at different statistics and data, and then they compile this report that basically has recommendations on how to deal with a problem. So what they found in this report in 2011 was that every year we spend about $635 billion dealing with a problem of pain management. So that's a huge sum of money. And you may ask yourself, well, where does all of that money go? So about half of that is due to the incremental costs of healthcare. This is hospital visits, doctor visits, and about half of that is due to the loss of productivity, missing sick days from work. So that comes out to be about $2,000 for everybody living in the United States. So how do you actually put that into perspective? $635 billion is a huge number. How do you quantify that, and how do you wrap your brain around it? So this is 450 Park Avenue, which is only the newest, hottest real estate development in New York. In fact, the top penthouses here retail for about $90 million. So this is the ultimate lifestyle of the rich and famous. And this specific building cost its developer about $1.5 billion to build. So if every year we're losing or spending $635 billion on a problem of pain management, it's equivalent to about 400 of these buildings being wasted each year. So what else did the Institute of Medicine say? These are direct quotes or citations from their report. And what they actually said is we should be looking at pain truly as a public health challenge. They said that given the burden of pain in human lives, dollars, and social consequences, relieving pain should be a national priority, and all healthcare providers should keep their knowledge current by engaging in continuing education programs, licensure and certification, and recertification examinations should include assessments of providers' pain education. So education is a key. Let's look at some of the pain statistics. So approximately 116 million Americans live with chronic pain, and it's more than 60% of those that live in nursing homes actually report pain, especially arthritis is a really debilitating, painful condition that can be severely painful. And we'll be looking at arthritis in more detail in our osteoarthritis and rheumatoid arthritis lectures. Nearly 17% of population have substantial daily pain, and more than 1/4 of adults said that they've experienced low back pain, and 15% of adults experienced migraine or severe headache in the last 3 months. So given all of the statistics, it's not surprising that when we look at chronic disease states or chronic conditions within Americans, we always talk about cancer, we always talk about stroke, we always talk about coronary artery disease, CAD, or diabetes. But chronic pain is really the most prevalent of them all. We just talked about that. 116 million Americans. So chronic pain is definitely the #1 most prevalent chronic disease state in America. So it's not surprising that the use of analgesic drugs is actually on the rise. So what are you looking at on this slide? You see there's this two different graphs, and on one axis, the y-axis, we're looking at categories of different drugs: antidepressants, analgesics, anticoagulants. And these are two different time periods, from 1988 to 1994 and 2007 to 2010. Versus here you have different population demographic by age. So this is 18 to 64. So basically everybody, all your working class, working force, and this is senior citizens. So you see that from 1988 to 1994 versus 2010 to 2007 to 2010, excuse me, the use of analgesics actually increased. And this is actually, clearly seen for both age categories. So given the statistics, it's not surprising that death, which involve the use of opiate analgesics, perhaps overdose due to use of opioids, these are actually on a rise. So you see here 3 different graphs. This one is looking at ethnicities, this one is looking at genders, and this one's looking at different age categories. And you see the rising trend in every single one of those graphs. So what that tells you basically that in both genders, in all ethnicities, and in all different age categories, deaths that are involving opiate analgesics are rising. In fact, in some states, death due to opiate analgesics are such a big problem that the state government, police, and firefighters, they put together these little naloxone kits. And naloxone is an opiate antagonist. What it actually does is reverses the effect of opiates, and hopefully, if it's administered in time, it can restore breathing and prevent somebody from dying due to opiate overdose. So you see there's a bottle of injectable naloxone here, there's a syringe, there's some alcohol swabs, and there are latex gloves. So these are the kind of kits police and firefighters carry on themselves in that state so that they can administer naloxone right away. So we talked about what is naloxone. It's an opiate antagonist, and there's about 60 pharmacists now in Rhode Island that are under the collaborative agreements, meaning what they do is they can dispense naloxone if you just come to the pharmacy. The pharmacist will be able to give it to you. So let's look at some of the barriers in pain management. So some of the barriers that Institute of Medicine report described were provider lacking knowledge, competency training. So physicians that are actually treating pain, for example, primary care physicians, probably the physicians that see the most patients, because everybody comes to them for the initial visit before they're actually referred to the pain management. Well, 27% of those PCP or primary care physicians actually reported that they felt somewhat unprepared. So either they lacked some sort of training or competency, but they weren't able to handle the problem to the best of their ability, or they felt unprepared to tackle it. And also inadequacy in subspecialty training. Perhaps these physicians didn't get an adequate training on pain management. And also some of the systematic and organizational barriers. So what does this mean? So let's say you're working in the hospital, you're a physician, and you would like to prescribe a compound P212 for treatment of osteoarthritis. Unfortunately, in your hospital, the only NSAIDs that you can prescribe are oral NSAIDs. So instead of prescribing compound P212, you can only prescribe ibuprofen 200 milligrams Q every so often hours because that's all you can do. So thank you so much. This concludes the end of Lecture 1. We'll be moving forward to Lecture 2 onto Pain Management 102.